I think we'll pick up on a couple of points of view. We are going to cut this panel in half. So if I'm going to start off, actually just going to make one comment, which actually is on the public hospital system. It's bad enough that it's 150 million and it was meant to be 45 million at the time. We didn't like it at the time. And what breaks my heart, even when we talk about, Bill made the comment this morning about, the hospital groups and what's happening. A roadmap is set out, and whether you agree that roadmap or not, the journey is commenced, and then it seems to disintegrate. And I think that's so disheartening on a strategy. I accept you have a plan, you've got to work the plan and plan the work and all that, but when it's just ignored, it's amazing. In this particular case, and it's on the Dáil record, that it went in, and this is the consolation we had at the time. We were told that if it's 1 penny over the 45 million, that they would be back in the Dáil and they would reduce that amount. That's what we were categorically told. Well, I met the Minister and others with the rest of the insurers there pretty recently, and the general vibe came back, not just from the Minister but also from his officials, was not in a month of Sundays will that be changing. And that, in my view, is really at the heart of a lot of what happens here. A roadmap is set out, assurances are given, and the next thing you know, it counts for nothing because there's a change of government, a change of personnel even. Sometimes it's not even a change of government. Anyway, without any more rant on that, I think it's one of the fundamentals we have to try to get to the bottom of for any roadmap we set out here, or for keeping the patient at the heart of what we're doing. Dermot, I'm going to come to you anyway, straight away. Is that okay? Not particularly picking at you for anything you said there, but in the past, there was, I would put it a higher trajectory on the switching market. But today, just in the last, let's say, 12 months, there's far more stickiness in the market. Why is that?
Sorry, can everybody hear me? Yes. Yeah, I mean, I don't know exactly why, but let me just throw this out there. I mean, the reasons why people don't switch, inertia is obviously one reason, and look, there's not a whole lot we can do to, let's just say, address that, but the amount of people, particularly older people, who are fearful of change. I mean, some of those older plans that are in the marketplace, anybody who's on the same plan for 3 years or more, or has everybody on the same plan, is basically overpaying for their cover. The problem is, though, people believe they have to reserve waiting periods. No, you don't. They believe they will be subject to age loadings. No, you won't. In fact, the only two questions an insurance company can ask you if you're thinking of changing: what plan do you have and how long have you had it? And we really need to drive that message home. And I would say to everybody in this room, people often say to me, well, my mum and dad, they're on the same plan and they won't change. Like, my father-in-law is on the same plan for the last 10, 15 years, and that's probably because he doesn't trust anything I say. But anyway, that's a separate issue. But what you really need to do is, somebody in the family needs to help them, needs to hold their hand and do the research for them. And you know what? If they phone up the insurance companies, and I have to say the insurance companies have significantly upped their game here in terms of fact-finding and trying to basically make sure whatever recommendation they give basically meets your requirements. The central bank audits them, all the calls are recorded. So never buy online is my message ever. Talk to the insurance companies, ask the right questions. And you know what? The Irish psyche is really funny sometimes, because people will say to me, well, I phoned them up, and I'll say, well, did you tell them all your medical problems? Oh no, I'm not going to tell them that. I say, well, hang on a second now. How are they going to give you that advice? So tell them everything. Tell them what's important to you, what hospitals, what doctors, what procedures, what your tolerance is for excesses, and then tell them to basically, now I want you to check across all your plans, okay? Every plan you have, corporate, teacher, nurses plan. And if you like what you hear, then switch. And really, Donal, I'll answer to your question. I say to people, well, what do you do in car and home insurance? Well, I shop around each year. And if you like what you hear and what you see, you switch. There's too much of an emotional attachment to health insurance. There's too much loyalty in the market. Loyalty just costs you money. It's as simple as that. It's an insurance policy. And the more we drive home that message, I think more people will shop around. They won't downgrade when they shouldn't downgrade, but they'll also find themselves on the right plan, and that's in everybody's interest.
I'm seriously regretting having asked that question.
I knew you'd say that.
Okay, before I go on, actually, I have a couple more questions here. Thanks, Dermot. Does anybody in the audience have a question? We're limited in time, I know that. I'm sorry. Could you identify yourself? I think is it Charlie there, is it?
Has Wi-Fi, video games.
Yeah, Charlie Hardy. I'm doing some consulting. I used to work in the department up to a year and a half ago. So there's a new strategy coming. Regulatory change will probably come with it. So what does the panel think? What do they want to see in that new strategy and change in regulation to promote and enable innovation and discourage inefficiency? So the public the private health insurers might enable the private systems to take a lead and possibly drag the public system after it to produce a better overall system to the benefit of the private system's business models and also for us all.
Does anybody want to pick that particular one up? Tim, do you want to pick it up, or I might come back with you then?
Okay.
Help us to help your local children.
Yeah,
by
okay.
supporting
Well, first of all, I mean, I think it's to be sort of strongly welcomed that the government are looking at a sort of a longer-term 10-year vision. I think they have a very challenging timeline that they're looking to try and sketch out what a future healthcare model for Ireland and to meet the demographics that are hitting us and how to best respond to that. I mean, there's no doubt that we have to change the model of care, and that's going to involve a dialogue between policymakers, between providers, both public and private providers, and there's a huge overlap in our market between both, and also then payers and insurers, and indeed customers who are more and more having, with these excesses, they have skin in the game and who are making decisions about the type of care that they receive and where they're getting that care. So I think it's going to have to be a societal discussion in terms of how are we going to change our care model and adapt it in a way that's better able to meet the changing nature of the healthcare needs of our population. And once we have that blueprint, then I think the funding bit is easy. The funding bit just comes. I think the key piece that needs to be agreed up front is what is the appropriate care model for the country? And then how are we going to finance and pay for that? And that can be done through a combination of taxation, private insurance, out-of-pocket expenses, and so on.
If it's okay, my own view, this is a couple of different ways of looking at it, and I would go back to the point I made there earlier on. I would not throw out all the old plans. A lot of those had good work in them that should not be revised or completely changed. In the first instance, they should be gotten back to, for example, the hospital groups I would start with. The other one then, I would fundamentally think that the settings, we need centre of excellences of all settings. And we fundamentally have to go back to putting the patient at the centre of what we're doing. If you're looking for outcomes and best outcomes, that's the philosophy you have to follow. And the mechanism of getting that is have the appropriate settings. Now, some of the conversations here today would be challenging, and I accept the vein in which they were said with regards sustainability and where we're going forward. But there's a particular emphasis here on today's conversation in acute care. I do think it has to be opened up considerably on the preventative care side. I do know that the Healthy Ireland initiatives and everything that went along with those, that is on the right path in my view, and there's a whole stream of conversation that has to take place in the new strategy with regards preventative health, with regards looking at the appropriate settings, and I genuinely mean you have a centre of excellence even at the convalescent stage, even at the chronic disease management stage, from a preventative as well as an acute care stage. Does everybody understand that? But anyway, that's my perspective. Without that, is there any other questions for the panel?
First of all, Ambrose McLaughlin again. I compliment you, Donal, on what you just said. And the question to the panel is that we do have to focus on prevention. We have to focus on predicting people's conditions in the future. I mean, we can't go on just allowing it to happen by accident. And we have to look at how we protect people. So I'm going to put a thesis to the panel that I believe the acute hospital system is a model of a century ago. I believe the model of outpatients, we've had a telephone for 135 years. We're not taking the benefits of the technology, and this comes back to what you've said about Healthy Ireland and other initiatives in prevention, but it's the same in terms of technology. So the question is, how do we design new systems? And there was reference to Kilkenny, and I'd recommend that people do visit Kilkenny, because the key to the new ambulatory care centre in Kilkenny is that the primary care people own their patients. They don't become owned by the acute hospital system. And here's the question. How do the insurers respond more dynamically? And in fairness, I want to accept that they have. In particular, some of them have gone a distance in primary care. How do they go the next step to ensure that we develop new appropriate environments for managing the chronic disease tsunami? And the next question I will have is, how do you encourage a different skill mix in terms of the delivery of care? Because the bottom line is that we are well into the mature phase of our current skill base. We need to look at at new disciplines and new ways of treating patients and new ways of preventing disease. So the two questions are clear, really. How do you accelerate the involvement of the insurers in prevention, protecting and predicting care in new environments, and how do you change the fundamental issue, which is the elephant in the room, which is the cost base of the system? That's another component. As a former civil servant, I can say now, the deficit in terms of governance relates fundamentally to our proportional representation system of election, because everybody will want everything at their local doorstep. And we're not going to overcome that, and until we deal with that, we won't deal with the macro issues. So they're the two simple questions. Thank you very much.
Yeah, very simple there, Ambrose, thanks. Dermot, Dermot, do you mind if I ask? I wouldn't mind Patrick's opinion, first of all, on the, if you don't mind, I want to pick up on particular the chronic disease management element and the Dutch perspective. Would that be okay?
Yeah, okay. But I completely, is it working? Yeah.
I think so.
Okay, I completely agree with the questions. I mean, I think, you know, what would be like in all countries. I mean, if you look at the top 1% most expensive patients, where there is basically huge waste. I mean, for example, in the Netherlands, this is like 60,000 euros a year, annually. And many duplications and stuff, and it's all hospital-based. I mean, 90% of those costs are hospital-based costs. They're not primary care costs, they're not about prevention. And most studies show that these high-cost, high-need patients, you know, you can reduce, say, easily 10-20% of expenses. Now, if you can do that, you can, I think, actually build the chronic disease management models and the primary care plus models which you mentioned. Because, of course, we come from a history with, on the one hand, the big hospital, and on the other hand, 100 years ago, a practitioner who works like in his own office somewhere near the house, with very few things in between, which is a huge problem, because that's basically what the future is. But we cannot afford to just, you know, pay, you know, additionally for this infrastructure which we need for chronic disease management for patients with comorbidity, etc., etc., etc. So we need somehow to save it from the current system, and my argument would be to look very carefully at those, you know, like top 1% patients, because there are many strategies which actually improve their health and might reduce their costs.
Okay, very good. Dermot, do you want to come back in there?
No. Sorry, the only comment I was going to make is that, and whilst I don't defend the insurance companies that often, but you know, let's go back to one of the themes of the conference in terms of partnership. I mean, how can you invest in some of these services, which we should be investing in, when one of the key partners, one of the key stakeholders reneges on previous commitments? You know, and that 150 million, I mean, some of the figures that were thrown out last night, that could now be 250 million next year. And that basically has to be coughed up by the insurance companies. We could do a lot of what you just mentioned, Ambrose, if there was a proper partnership approach and that 250 million was ring-fenced and was invested in some of those services. So, you know, it goes back to when you have one of the key stakeholders is basically banging heads against the other key stakeholder, well, you know, key services like that will never materialize. And that's, I think, that's just, it's a shame, to be quite honest with you.
Okay, Dermot, thank you. Much of what I would have to say, for example, on the cost base, actually, I would try to answer the strategic question first, which is I don't know the answer to straight up. I do know that we have to eat the elephant one bite at a time. And the current challenge is that whatever roadmap is produced now actually becomes something that's bigger and longer than the projected government that's in there. That would be my opening solution, let's put it that way, if that's the right word. Folks, we are running out of time. One last question then, and we'll cut it off. Is that okay? And if there's no burning question, great. We'll just head to lunch if everybody is agreeable with that. I'm getting none. Great. I'd like to thank everybody, thank the panel for all your contributions.